Call upon the next Dr. Pankaj Dongre, Central Toxic Keratopathy Post Collagen Crosslinking.
Yeah, good morning everyone. So my free paper topic is central toxic keratopathy post collagen cross-linking. So we have been known that collagen cross-linking is a effective procedure for halting the progression of the keratoconus. But we also know that there are some complications related to collagen cross-linking, especially microbial keratitis post CXL, the haze, reactivation of herpetic keratitis, and various the microbial infection. So CTK is one of the sequelae of collagen cross-linking which has not been reported yet. So there is no financial disclosure in my presentation. So the purpose of this study was to report a case series of central toxic keratopathy following collagen cross-linking in keratoconus. So it was a retrospective case series which was done, which included the patients who had underwent CXL for progressive keratoconus from January 2020 to September 2021, and we included, we have done CXL for about 964 eyes in this period, and the protocol which was used was the epithelium of accelerated protocol. The cross-linking system, the machine which was used was the Avedro KXL cross-linking system. As we have used the accelerated protocol, we have given the riboflavin soak time of 20 minutes along with UVA light exposure for around 10 minutes. After the procedure, the BCL was applied and it was kept for around 1 week along with topical low potent steroids in a tapering dose for over 4 weeks, along with topical antibiotics for 1 week and topical tear substitutes. Out of the 964 patients, the 12 patients were noted to develop CTK. The age group were of all the patients were between 16 and 32 years, and there was no any sex predilection. Equal number of males and females were noted. So this is a table which shows all the patients. The interesting thing which we can see here is like all the patients they presented within 1 week of the after the CXL. They all had the characteristic features of CTK, which I will be discussing in my subsequent slides. So at 1 week, this patient presents with this kind of clinical picture where we can see there is stromal opacity which is central in location. You can see there is no any congestion on the conjunctiva, and also we can see there are striae which are radiating from this opacity. The striae are nothing but the folds in the Bowman's membrane. The same picture in the slit image. As I told, all the patients they presented within 1 week. They had the central dense stromal opacity. No opacity was noted in the periphery. It was localized. The margins were very distinct. There was stromal thinning under this opacity and the presence of striae. As you can see in the ASOCT picture, the opacity was more in the anterior stroma, and as you go towards the posterior stroma, the density of the opacity and also the area of the opacity was decreasing, and it also shows a very characteristic inverse dome shaped pattern. When we performed corneal topography in these patients, what we found out interestingly is that so this is the pre-op topography where K1, K2 is noted around 45 and 51, whereas at 1 week the cornea became flatter. K1 became to 43 from 45 and K2 became around 47 from 50. So there was flattening in the cornea. The confocal microscopy performed at this visit at 1 week shows no any inflammatory cells, but there were activation of keratocytes. As we followed up these patients, this is the example of one such patient. We can see at 1 week, 1 month and 6 months, the density of the opacity decreases. There were striae, and also the ASOCT shows the inverse dome shaped pattern, and you can see just below the stromal opacity there was thinning of the corneal stroma. Again, this is the graphical representation which shows that in the acute phase of the CTK, there was corneal flattening, but in the remodeling phase the cornea became little bit stiffened, but the stiffening was not more than which was there in the preoperative level. That means the cornea regained its structure but less compared to the preoperative level. Same in the K-max. The pachymetry you can see there was thinning in the acute phase of the corneal stroma. So CTK, as we know, it is a acute non-inflammatory self-limiting condition which is most commonly seen after post laser refractive surgery, commonly seen after LASIK, and it is associated with, as I have shown, central corneal opacification with stromal tissue loss along with striae. And as there is stromal tissue loss, there is significant hyperopic shift in these patients. Interesting thing is there is no case, this has not been reported after cross-linking. This is the mechanism how the hyperopic shift occurs, because there is loss of stroma, the anterior surface falls back and fills the gap, thereby causing flattening of the anterior surface of the cornea. So these are the probable external factors which play a role in the formation of CTK, maybe the meibomian gland secretions, marking pen ink, the talc from the surgical gloves, or the photoactivation of povidone iodine by the excimer laser. As we can see, the density decreases over the time. It's a self-limiting condition. We need not to intervene actively in such. This is the again topography which shows at 1 year the cornea again remodels, but the steepening of the cornea is always less compared to the pre-operative level. Same thing with the ASOCT. So as I told, as the disease, there is remodeling of the cornea and there is reduction in the hyperopic shift.
Time is up.
Yeah, thank you.
So how long did you follow up the cases?
Yeah, so few of the cases they follow up till 1.5 years. By 1.5 years, the opacity fades away. Yeah, 18.
What's
Thank
the
you.
one test you will tell to distinguish between stromal haze post C3R and your CTK? One test.
ASOCT, because ASOCT will show a demarcation line in case of post CXL haze, whereas there is no any demarcation line in CTK. It gives a characteristic inverse dome shape pattern.